Hello, everybody. My name is Susan Dunn, and I'm the Director of Activity-Based Management in New South Wales Health. Today, I'm presenting on behalf of myself and my colleagues, Olivia Hibbert, Richard Macon, and Julia Heberle, and also on behalf of all of our clinicians and managers who we have worked with to get to the point where we are confident that the costing model we have built for highly specialised therapy is appropriate to be funded. The purpose of this presentation is to identify the journey New South Wales took, along with IPA and the other states, once Minister Hunt announced funding for ALL. That is refractory acute lymphoblastic leukemia for children and young people. This was announced in April 2019 and was the commencement of funding highly specialised therapies within Australia under a version of activity-based funding. This funding will cover all costs of care of the entire highly specialised therapy journey. The presentation will highlight some of the key issues we've had on the journey in relation to activity and costing, as opposed to the clinical journey, which Olivia has led. It was essential when we started this journey to understand the impact of genetically engineered therapy on patients and how the preparation for cell manufacturing occurred. This may seem to be an odd point to discuss, but it's probably the part of costing that we had least focused on before, and that is to ensure all pathology activities are included. Once the Minister announced the funding, IPA led a workshop to get national agreement on a way to identify and cost the clinically appropriate pathway, so that these costs could be submitted for the purpose of funding and reconciliation. Reconciliation ensured an appropriate risk-sharing methodology between the states and the Commonwealth existed. It was also a requirement by the addendum to the NHRA, and it's unusual for block-funded services to be reconciled. However, it was particularly significant because it allowed the clinicians to be confident that this service would be fully funded. The risk around this particular service is that it's low volume with exceptionally high cost. As the funding is under the NEC model, we provide an estimate of cost to be funded for the financial year prior to the financial year. An underestimation of costs would leave a potential shortfall in funding. And this is where reconciliation becomes important, as it gives us a safety net that if we had underestimated the costs, the Commonwealth would adjust the funding at the end of the financial year. However, if we had overestimated the cost, the Commonwealth would want their money back. Lastly, the knowledge we gained during this process was then used to develop the New South Wales Highly Specialised Therapy Costing Guidelines, which was incorporated into the New South Wales Clinical Accounting Guidelines, which reflect how New South Wales cost the hospital care. It's also then used towards the National Hospital Cost Data Collection, which, if highly specialised therapy is to be truly part of mainstream ABF in the future, they will need the cost to work out the appropriate funding model and price weights. During the process, we did many things, but we're going to particularly talk about two, and that is clinical engagement and identifying particular cost considerations. We held multiple meetings with our clinicians to connect with them and to build their trust that we would understand, or try to, all of the work that they were doing within this journey, and that we can ensure that costing covers all of that work. We initially met in Melbourne on this workshop to go with the clinicians, managers and ministry representatives, as well as Commonwealth reps, so we could all understand the pathway and that we're all following the same principles. And that was at least about where the journey started and ended. We talked earlier about having 12 months worth of this journey, but it often goes over 2 financial years. The patients that come into hospital or go to outpatients or go to ED are all covered under this 12-month journey. And the relationship the patients have with the hospital and how often they come is very varied based on how they react to the treatment. All of those details, though, all of those encounters they have over that time period are all funded through this process. So as part of that meeting in Melbourne, we initially had to decide on the starting date of the journey. And that was acceptance to program. We all agreed that acceptance to program would initiate the 12 months. We then had to have a look at the costs of preparing cells for manufacturing, the cost of any bridging therapy the patients required, also the cost of their infusion stay, which is usually a 4 to 5 day stay in hospital, and then the point at which the journey would end. So getting the cell infusion date is crucial because 12 months post that date is the end of the funding for this particular journey. So all of the costs within these steps in the time frame had to be identified and allocated to the correct patient. To do that, we actually had to make sure we had the correct dates of all of these things: cell collection, acceptance date, infusion date, 12 months post-infusion date. And this sounds really simple, but it actually was quite a data collection challenge, because getting things like the MRN right and not transposing numbers, or entering the correct date and not, for example, ending up with an American date, is actually really difficult when you're doing a manual system. And at the moment, all we have is Excel while we're looking for a better solution that's automated. The second area I want to discuss is about costing considerations. And in those costing considerations, a number of things came up. But one of the big things was regarding pathology and all of the laboratory services and activities that were undertaken. The project led by Richard was in response to specific medical and pathology concerns that pathology processes weren't really adequately understood. The aim was to create a pathology activity reporting methodology that enabled pathology to count their contribution to the process and be appropriately funded. It was important to work with the model that pathology already had in place for cross-charging hospitals for their services. This was crucial so it didn't get missed and bills did not go out. And people didn't just forget to include these bills and hence the costs, so that we ensured it was all part of their normal workflow. Another issue we had in costing was around the supply invoice allocation. There's a third party who does the cell manufacturing work, and we had to ensure the cost of that work is allocated directly to the actual patient it applied to. And this is particularly because there are two payments over the journey, and the payments differ slightly, particularly the second payment, which is based on what's happening during the journey and how the patient reacted to the treatment. It was crucial to cost this correctly, to ensure that it was crucial to cost this directly, as the cost of this is quite significant in the overall journey. We then used this knowledge to establish the New South Wales cost accounting guidelines, which provided the costers with a standard methodology to ensure all of the costs of highly specialised therapy care were identified and collected. The costers have worked tirelessly with us to ensure that they have relationships with the doctors in the hospitals to understand all of the minutiae of detail that's required for a full clinical costing study. Looking at the results, as part of Richard's project, we built what we've called the New South Wales CAR-T non-MBS codes for pathology. Now, that word CAR-T has caused its problems in itself, because there are many ways of describing these patients: highly specialised therapy, HST, CAR-T, Kymriah, and we're still trying to ensure that everybody understands we're talking about the same group of patients. But it certainly had its own challenges. Richard's work identified 4 activities: cryopreservation for CAR-T, dispatch for CAR-T, manufacture, receipt of CAR-T, and release of CAR-T. And each of these activities have different costs. And the costs that were included were staffing costs, equipment costs, quality control costs, and consumable cost. And of course, we had to remove capital costs out of there because they're not part of ABF. Interestingly, the pathology cost ended up being less than the clinicians originally estimated it would be with us. So when we then built the non-MBS codes into the billing system, the total cost of each of these activities could then be billed back to the hospitals to ensure pathology was automatically funded for their service. The second part of the results was actually around the individual encounters, but shown here in the level of stages. Earlier, we showed you those stages: acceptance date, collection date, infusion date, and so on. And they're there in the legend below. Pre-program costs were excluded because they weren't part of the administrator guidelines, although they were parts of costs that New South Wales themselves were interested in. The infusion time you can see here in yellow is actually the episode of care where the patient has their cells infused, and that normally involves an inpatient stay at the moment. And it also kickstarts the first payment to the third-party manufacturer. But the key here is showing you that under the addendum and the reconciliation rules, We need to provide costs at the end of September following the financial year. Now, this is different to the rules that we normally work under for the NHCDC, or the National Hospital Cost Data Collection, which requests submission in February following the end of the financial year. IPA also have a principle that says you collect information once and use it many times. However, the part of the addendum that says we have to submit these costs at the end of September really challenges this principle and our ability to undertake a full costing study by the end of September. The way of potentially resolving this is to do standard costing and at least have the first reconciliation based on the standard costing, with a potentially smaller and later reconciliation after the National Hospital Cost Data Collection is submitted. I think the slide highlights an issue with that though, because the clinical journey of these patients is over a 12-month period, but it normally runs over 2 years, and we cost each financial year independently. You can clearly see in this example, which is one hospital for ALL, that the patients are all at different stages of their journey in this 12 months. So standard costing such a varied clinical journey would be quite a challenge, and it puts at risk the trust we've built with the doctors that highly specialised therapy would be appropriately funded. In conclusion, the exercise has highlighted the challenges associated with working up bundled model payment models for complex patient journeys, and it's been a great learning experience. Partnering with the clinicians at the local, state and national level is paramount to the development of the innovative funding models, but so is partnering with IPA, the administrator and the national funding body. It's equally as crucial to understand the challenges that we have in providing this information to the administrator as an input for the purposes of funding. Luckily, we have a great relationship with them and we are able to continue the negotiation and discuss the challenges of providing the costing data for highly specialised therapy. This has been an incredibly useful exercise over the last 2 years, and we have gained a lot of experience in regard to working with innovative funding models and bundle payments. Thank you.